Good morning, everyone. I hope you had a good evening last evening. Today's morning session will focus mainly on the EQUIST site and walking through the EQUIST site. If you have your laptops open, we can navigate to the EQUIST page and feel free to play around with it as I go through, and please feel free to raise any questions in the middle if you run into anything that you don't fully understand, and I'll be sure to stop and we can make sure we cover all the concepts. So the website itself is equist.info. It's written on the board as well, and that's just what you need to type into the web address bar. And once navigated to the site, you just need to log in. It's on the top right-hand corner, and put in your login credentials. And once that's done, you should run into the dashboard. When everyone's there, feel free to let me know, and we can continue from there so we can go over the layout of the dashboard. Maybe I should click to a country. Has everyone made it? Okay, excellent. So good. Starting on the main dashboard, what you'll see on the layout here is on the top right-hand side. The first thing you could navigate to on the top right-hand side is the language settings. So we have English, French, and Spanish at this stage. There are other languages being added. Arabic and Chinese are being worked on. Their characters have to just be developed and incorporated onto the site. So those are works in progress. In the middle top hand menu, you'll see a country menu. And it's not technically only just a country menu. What you'll see are other subnational areas. What we call these are workspaces. So these workspaces are just set up to focus on a specific data set and for either a specific country, region, or subnational area. Since the focus is on subnational planning, there is this focus on incorporating new workspaces at lower levels, so looking at more subnational areas. One good example of this is for Ghana, and this is mainly the example I'll be using going through this demonstration. So if we, for example, click on Ghana and select that as the country workspace, we'll automatically see a map pop up with the default workspace that's shown. So this is Ghana 2017, which you can see on the left-hand side menu, and it's showing Ghana mortality data by region. So the top of the image shows the title of the chart in case you're want to see which indicator intervention you're looking at. So the under 5 mortality rate that's covered here is coming from IGMI, the Interagency Group on Mortality Estimates. So IGMI does not report subnationally. So you might ask, how do we get subnational figures? And that's the reason why we use IGMI is because nationally it gives you the most recent mortality estimate. But for subnational, what we do is we also collect the subnational data from the survey for that year. So if it was, in this case, it's the maternal health survey that they had for 2017. Usually it's a DHS or mixed survey. When we get that subnational breakdown of the mortality estimates, we proportionate the national IGMI figure to the subnational level data to get the trends in mortality among the regions for that year, to give a more up-to-date figure for mortality, more recent figure for mortality subnationally. When we look at the bottom, as I just pointed out, there's the source as well, and you can see when it's last been updated. on the bottom left-hand side of the visualization, you'll see a scale. So if we're looking at mortality rate for among under fives, what you can see is the deaths per 1,000 live births. If I were to hover my mouse over one single region, it should show you by arrow exactly where on the scale this falls in terms of severe, high under 5 mortality rate or lower under 5 mortality rate. For comparison's sake, this scale has been kept standard among the different data sets, just so we have it for comparison. Before, we used to adjust the scale based on the map, but the feedback we received was when they wanted to look at a trends analysis, they wanted all the scales to be the same for comparability. And if you can mouse over any of these regions, you'll get a little bit of data through this tooltip, which shows you the indicator name as well as the figure. So this is more of a dynamic, slightly more dynamic form of mapping that we can take a look at. For comparability, one might want to look at a map, or it might be easier to see this data as a chart. So here, what we see if we click a chart on the top left-hand side is the same data, but captured in a chart form. What you'll have in addition is the national average for Ghana. So you can see how each region stacks up to the national average. If you wanted to sort the data a bit, you can do so alphabetically. I think it's alphabetical by default. You can be alphabetical, or if you click it again, reverse alphabetical. Or what I tend to do is I look at the data by value, so maybe lowest to highest. So you can see in terms of under 5 mortality rate, maybe I can make this a bit more interactive. What are the top 3 regions that have the highest under 5 mortality rate in Ghana 2017?
How frequent are these surveys that happen? Is it like 2017? Is it every 2 years?
If it's household data, we're looking at 5 years apart. Yeah. If it's a country that does both the DHS and a mix, and there are some countries like that, it may be 2 or 3 years apart that they want to incorporate this data. If it's routine data, it can be twice a year on average, or more frequently depending on if they get data and immediately enter it. There's a few APIs being developed, and they're programming linkages that can look at automation, data automation. So if a new DHS comes out, that data would be auto-populated based on a country's demand without any manual data upload. So that's currently in development. I've just met with the Delhi team on that, so that's something that's coming across as well. We're working to do the same for DHIS2, but DHIS2, the issue is data sensitivity. So they would, like more of a private space to validate the data first before publishing. So that's something that can be done at the back end, and that's something we'll have to put together.
And who conducts these surveys within countries or the areas? Is it these teams, or is it National Ministry of Health?
So it's usually along with the Ministry of Health with the mixed surveys, multiple indicator cluster surveys. They work with UNICEF to publish the mixed survey data. With DHS, I believe it's USAID that funds countries to actually undergo and take on these surveys, collection of data and validation of data through sample sizes. Yeah, and then there are other national surveys. It's not only limited to those 2 surveys as well. With the DHIS2 and the routine data, we're looking at entry through health facilities. So that's more health facility data that's coming through, and it's by cases. Yeah, so this.
So
sure.
DHIS2 will not capture deaths that don't occur in facilities.
Exactly. That's the thing with, and that's the issue with routine data and DHIS2 data, is that it's not representative of, let's say, a district, of the entire district, but it's only going to capture the facility deaths as well. That's a very good point. We've run into, I think, mainly with the HIS2 data, we've run into some issues as well in terms of accuracy of the data. When we're looking at mortality, for example, in Ghana, and you'll see the district level data for Ghana, that there were some estimates that were 0 for certain districts, which we met with the focal points, and they also agreed that it's not accurate. So we had to, in those cases, refer to other sources that are available that would more accurately reflect. Or if not, if there's no other data available, one can create missing data rules, which we'll also look at in sort of rules that they can apply for certain indicators, whichever indicators they specify later on down the road. And this can apply for the future if they set it up that way, or they can change it every year. But usually when they set up, let's say, a whole country page or a workspace in general, on its own, it could be automated. They can have it set up automated, or they can change it. So they can make it a one-time setup of parameters, or they can do it more frequently. Right. So yes, so looking at the regions, maybe I can call on someone to pick out the top 3 highest under 5 mortality rate regions. Does anyone want to volunteer? Western, yes. Northern, and Upper East, yeah. Now, you're looking at this in terms of under 5 mortality rate, but if you were to look at total number of deaths on the left-hand side by changing the unit, has the picture changed?
Wow. Very well. What a great example.
So you can see Ashanti, Northern and Western have the top 3 highest number of deaths. Now, what I'll just flip back to is what you just saw probably briefly, is if you click on both units, you can show side by side the under 5 mortality rate in blue per region, as well as the total number of deaths per region. Again, you'll have this under 5 mortality rate national line, national average line for Ghana, for national. So here, what this is used for is to help health policy planners, decision makers decide where they should allocate their resources to if they want to explore and analyze the data this way, is to look at, okay, we have Western Ghana. It's got a total number of deaths of around 7,000. So on the right-hand side, you'll see a scale for the total number of deaths. On the left-hand side, you'll see the under 5 mortality rate, deaths per 1,000 live births. So we have Western Ghana, which has, pretty sizable under 5 mortality rate. It's above the national average, and you also have pretty sizable total number of deaths. But then you also see the same for Northern Ghana. It has an even higher total number of deaths and an even higher under 5 mortality rate. But if you look at Upper East Ghana, it's got a fewer total number of under 5 deaths, but a higher under 5 mortality rate. And does anyone know why this may be the case, where it's a lower under 5 total number of under 5 deaths and a high under 5 mortality rate compared to Northern and Western? Exactly, population is huge. So when you're looking at short-term plans, what I've seen in countries is if it's a health minister who wants an immediate sort of impact, would they want to focus on addressing under 5 mortality more in terms of rates, on bringing those down? Or would they want to focus on total number of under 5 deaths? That's something that we've seen where you have institutions, organizations, NGOs coming in and sort of vying for trying to reduce the under 5 mortality rate so you have a longer term impact. So there's always this balance that health policy and program makers have to make. And this allows them to do that. They can categorize the regions using this type of visualization by looking at those, first of all, that have under 5 mortality rate above the national average, but also looking at total number of under 5 deaths and scaling, sort of balancing what they consider to be more severe and more high priority populations to focus on and to allocate resources to address mortality. Right. So very good on that. So what we'll also show you, you can also focus on, if you don't want to look at your analysis by subnational region, there is this by menu on the left here. If you select that, in this case we only have region. I may have to change the data set to Ghana 2014, for example. You can see if the data set has this, you can actually see the data by residence as well, so urban, rural, and wealth quintile. So in terms of, I think I have to set this up alphabetically. So this is interesting. The way they have quintiles set up in the surveys is they have the poorest quintiles at the bottoms, quintiles 1, 2, 3, and 4, and then quintile 5 being the richest. So here what we can see is it's still quite interesting in terms of under 5 mortality rate, because according to the DHS 2014 subnational distribution among quintiles, the poorest, as it makes sense, has the highest under 5 mortality rate, and then the next is quintile 2. But you can see that then quintile, the richest quintile, is higher, has a higher under 5 mortality rate than quintiles 2 and 3, which is interesting because then that brings up questions in your head. How does this make sense in terms of the richest 20% of the population having a higher under 5 mortality rate than the middle and the rich quintile? So this is something that one would need to explore in depth. And the first question, is it a data issue? Is it something that going back, should we explore the data again? And if you do and you still see the same result, which is what we normally see, then we approach the country and ask them to take a look. I think the most recent example of this has been Kyrgyzstan. They've come out with their DHS 2000, the Mix 2018 survey, and there they had a similar result where even the richest in terms of neonatal mortality were doing worse than the poorest, or having higher neonatal mortality rates. So this is the sort of thing that we'd have to go back to the country and ask if we can explore and revalidate the data. And
take into account the demographics of mother's age, or by which method they're having children or something like that?
Yes, so if that data is available, that can be captured as well. So that can come out as one of the variables on the left-hand side, and that's something we can see. The ones you just saw, the urban-rural, the subnational province and district, and the wealth quintiles are all just standard defaults, but you can add that as well to add more to the analysis and to maybe find out the reason why this is occurring.
But look, this clearly doesn't make any sense. I mean, the trend makes sense and it looks great up to the point where we come to riches. I mean, two most obvious explanations are that either they only really in DHS captured correctly the deaths per 1,000 live births when they were in the wealthiest part of the country, and they systematically were not capturing deaths as they moved away, and the data became worse and worse, and therefore they found less and less deaths, which they should have found them more.
Sure.
So another one is that there is something odd with how they define riches. Maybe they just define riches being the capital city, and
Yes.
the capital city may have some shanty towns or
Sure.
or very dangerous slum regions where you
Yeah.
actually have worse situation than you have in the rural regions.
Sure.
So I mean,
That's true.
there is some artifact there clearly, because I cannot believe this.
Yeah.
It's just not,
And I think also actually I think it was Kenya that had their neonatal data as well, mortality data, which showed an opposite trend as well. So it could be due to, as you're saying, the slums. That's what the original thinking was.
Well,
They're
it's
counting
one
them
of
as
the two
a.
things. Either these DHS are done far better in the wealthy areas and they really capture everything that's going on, and everything else is a vast underestimate of how bad things really are because they just don't do the job as well as they should. Or it's just that slums are captured within the wealthy areas and considered wealthy, whereas they should be separated from the rest of the context. So yeah, it's one of those. The things are both together, you know, maybe both combined. It's impossible to believe this.
One thing we could look at, and this is what UNICEF normally does, is they look at trends. So they look at a previous survey and do a comparison. So for example, with Kyrgyzstan, the previous survey didn't match up with the trends of the latest 2018 survey. So if we look at trends, let's compare the 2008 Ghana DHS to the 2014 Ghana. And look at the blue being Ghana 2008, the orange being Ghana 2014. If we look at it by wealth quintile, sorry.
Yes, by wealth quintiles would be good. That would help a lot.
Yes.
You would expect that systematically it went down.
Yes.
But clearly in the regions it went up. That's really odd.
Right. Where it had decreased in quintile 4 and 3. Yeah. And quintile 1 and 2 increased slightly, and the wealthiest quintile increased, I think, has the largest gaps in terms of increase of mortality, which is interesting. I don't know if it may be a 2014 data that's they would need to reanalyze for this.
Well, you know, there's a lot of uncertainty in all these. Kyrgyzstan rings a bell to me because when I was looking at Kyrgyzstan, they have data from survey to survey, which is all over the place. Like they had 20-fold differences between two surveys at some point in some data which I analyzed. So I realized in Kyrgyzstan certainly I would not believe any of that. And there's a lot of variation, and when the data are not of highest quality, then this is what you expect. You expect things to get to be all over the place a little bit.
Right.
So this does not. But I mean, I can now from this conclude that the poorest probably is around 100. I can believe that it didn't change much, but I cannot believe that in riches it went.
It had gone up by that amount. So we're looking at an under 5 mortality rate of 56 deaths per 1,000 live births to 68.
I mean, what could also explain is urbanization. You know, it could explain that there's been a massive influx from rural areas in the cities of the underserved population, which is not visible to the health system. And then, if those people are not seeking care because they're not even there legally, then that could also explain.
Contribute.
Because in China this has become a problem at some point where everyone went to cities, hundreds of millions of people, and but they had this hukou system where they only had health insurance in their province of residence. So when they moved to big cities, they were basically uninsured, and then suddenly the medicine, which was not kind of a parallel illegal health system, has been developed for those illegal migrants, so I'm wondering whether those same things operate in countries like Ghana. They probably do, right?
And it's good that you're bringing these up because that's what you're doing. You need to bring up the country context during this time, during both these data periods. Even though these data periods have a lag period, since we're talking about household surveys, it's good to think about the situation in the country and what changes that occurred that may have contributed to this as well. So you may see some bizarre trends here and there. So the first question you should bring up is, first of all, is it a data issue? And you can recheck if it's maybe a data entry issue. But when we do and we see that it's actually the data itself, then we go to refer back to the country office that, us being from UNICEF, back to the country office, that they speak to the government counterparts and find out what the reason is behind this, and then also looking at the context within itself that contributes to this sort of data trends.
I don't think it's an issue of definition, just like Eagle said, because in several African settings, urban slums, you see them, you look at them as they are actually wealthy. compared to the rural areas.
Right.
So you see that they will say urban slums, and actually the health status there is actually not so good. So it's an issue of definition, thinking that urban slums and all those areas, and which are actually people who move in from rural settlements to urban areas, and those areas are really not really good.
Oh, yes.
So and we have such in Ghana and in Accra. And all those
In
areas.
Accra, yes. So those are all good points. Just to move on from this, so this is something you can play around with. In terms of the dashboard, what we're looking at is the situation analysis, as you've seen, because we want to glean from the data sets. This is a situational overview of what the data is showing you for the country. If we were to, again, look at trends, you can see them by maps as well. So here's, again, Ghana, 2008, 2014, in terms of under 5 mortality rate. If you look at another source as well. So I think I had shown this yesterday, but from our earliest data set that we had was DHS 2008, and we have our DHS 2014. We have a mix in the middle here, mix 2011, which is the UNICEF survey. So you can see what I was discussing about yesterday, a roller coaster effect, where the subnational mortality, for example, for northern Ghana is lower in the mixed survey in 2011, and then is higher in 2014. So this is due to different methodology for estimating mortality. So that's why when we look at data, we normally try and compare the same survey sets. So we, for example, if you remove the mixed one, for comparability's sakes, and it has more of a flow normally in terms of trends. And so this is this also what allows a health policy program maker, a decision maker, to decide based on trends which provinces that they can focus on. Do they want to look at those that have an increase in mortality more in general? And that's one of the factors that they take into account, is in terms of looking at the provinces that have seen an increase in under 5 mortality rate. It seems to be Ashanti, Upper East, and Volta regions, for example. So one other highlight that we have is in terms of subnational regions. For Ghana, I think this was one of the first that we used for analysis. I think it's actually the first that we used for analysis in country, is to look at data through their DHIS2. So this is 215 districts that you can see here. So it's a very cluttered map. If you want to look at it in a chart view, which might be slightly easier and organize that. This is as far as we pushed EQUIST thus far, but I think it's going to go farther than this. We'll see how to even better capture this. You could zoom in to a certain area if you highlight it. So if you, this is done alphabet. No, this is done by sorting by data. So you can sort of focus in and see a subset of districts here in terms of how their mortality rates look like. Let me zoom out. If you click on Reset Zoom, you'll go back to the full picture. So in terms of districts, since there's so many, what we had to do is break down Ghana into different regions first, and then look at districts that way. So if I were, for example, to take Volta, Ghana, and look at the map for that. So you just have this one region of Ghana and all the districts within that region. So this may be easier to look at by chart. Yes. So in this specific case, let's look at a specific different indicator. So we've been looking at under 5 mortality. Let's look at intervention coverage. So to do that, you would navigate to analysis of on the left-hand side. And when you select that, you'll see a list of indicators. So first, there's demographic parameters. So there's your population, crude birth rate, average household size. size, etc. And there are more captured at the back end of EQUIST, but these are the defaults that are shown up front. And then you have epidemiological parameters. So these are your more disease-specific and mortality-specific causes. So here you can, for example, look at, if we scroll down, there's causes of mortality by, causes of neonatal mortality and under 5 mortality. And as we go further down, there's a lot more indicators we can look at. So if we look, for example, at, if I take a given intervention, if we look at MR2 coverage, measles, rubella 2, they just had their campaign there. So at the provincial level, it says that Volta has a coverage of 77% for measles, rubella 2. So when you look at a national map and you see Volta as one of the regions, it says 77, you might think, oh, that's a high percentage. You know, they're getting fairly good coverage of measles, rubella 2. But if you look at the district level data, what you can notice is that more, or approximately half of the districts within Volta have lower coverage, with the lowest being 50% coverage of measles, rubella 2. So there's this idea that, you know, when you have provincial level data, it may mask what's going on down at lower levels at the district level, and even with the district level data, it's masking what's going more down further at the subnational districts or sub-district level areas. So the idea here and the point here is that even though the situation in terms of coverage of interventions may look reasonable from the outlook, it might look like all of Ghana has high intervention coverage, when they're looking to reach their target of 90% of districts reaching 80% coverage of measles, rubella 2 or higher. They haven't reached that because of what's going down at the district level. There are root causes and root bottlenecks that are occurring within these lower subnational areas that need to be addressed in order to lower mortality and to improve coverage rates and to improve service delivery. So that's the major point here. One other feature I can just point out in terms of the map, and this is coming from the Ghana Health Services, the team that works on DHIS2 data. On the map itself had provided this information. So if you click on this gear icon, it's on the top right-hand side of the map. If you just select that, there are different layers you can select to provide additional information. So here, if I click on Ghana facility map, what you'll see are all the health facilities throughout Ghana. So what you can glean from this information now, looking at this, is you can use this for comparability's sake. So you can look at the areas with higher under 5 mortality rates, and you can see maybe the density of health facilities, or if they're more spread out. And the reason I'm pointing around northern Ghana is you can see how less dense it is compared to the south of the country. So in general, from what the data has been showing, it's that it's mainly the northern half of Ghana where you see northern regions having higher mortality rates. Whereas if you look at Greater Accra, Ghana, with the higher populations, and Ashanti, Ghana, and this is specific Kumasi here, where you have higher density health facilities, because these are the 2 most populous cities in Ghana. And so you can see, as Professor was mentioning yesterday, that there are these issues where you have more rural areas and lack of access to health facilities. This is something a health practitioner should take into perspective, or a health policy planner, that there is this less density, which is contributing to mortality as well. So this is looking at the bottleneck, so it's access to health facilities as well, and which populations are more remote in this case. There are other examples. We don't have it for Ghana because they didn't provide that information, but you can look at other geographical features. I know we had this for Afghanistan. If I navigate back to that, I'll just quickly go back to Afghanistan to show you this. So you can populate the health facilities and as well as lakes, rivers, and other geographical boundaries. You have just to show the difficulty of access to health facilities, especially for, let's say, pregnant mothers trying to access antenatal care. So this is the type of information we can, additional information we can take a look at. Going back to Ghana now, maybe we can take a look at some of the indicators as well. So if we go back to, let's say, Ghana 2014 again. So what we have, again, under the analysis of are the demographic parameters and the epidemiological parameters. And one of these that we can take a look at is under 5 mortality by cause. So what this shows you is, we're looking at this by province. Again, you can change this to residence and wealth quintile. Is to try and identify maybe the top 3 to 5 causes of mortality among under 5s, let's say per your variable that you're looking at. So if it's looking at northern Ghana, what the top cause of mortality is, it's saying malaria is contributing to the highest under 5 mortality rate, followed by other neonatal causes, because neonates fall under this group. Also, pneumonia and diarrhea are contributing to high under 5 mortality rates. And we can look at these trends across the other regions as well to see if they still hold the same pattern. And if you just wanted to focus on the top 3, you could click away some of the other causes and they disappear from the chart once you do so. If you want to add them back in, you just click on them again. So maybe you just want to focus on the top 3 specifically. If we just want to, back to neonatal. Let's say top 3 or 4. So this would provide a more focused analysis looking at the data by causes of mortality. So where this data is coming from, it's calculated from CHIRG, actually, the Child Health Epidemiological Reference Group for under 5 mortality. Okay, so to, I think, proceed, we can also look at, again, under analysis of the theme. There's a theme, a submenu here. If you select this, what you'll see is the 3 service delivery modes I mentioned yesterday. It's the interventions, how the interventions are categorized. So family care practices, preventive services, and curative services. Family care practices looks at the more behavioral practices done most likely done in the household by the mother. For example, if you select this, you'll see 3 health packages that I had mentioned yesterday: WASH, ITNs, environmental safety, and infant and young child feeding, nutrition. So if you click on one, for example, WASH, you'll look at the interventions under that specific health package in that service delivery mode. So if you're looking at safe disposal of child feces, you'll see in terms of coverage now what the intervention is showing you. We can look at this by map as well. So if you want to look at the areas that have the highest coverage versus the lowest coverage, you can see around what you could expect that the southern regions in Ghana have higher coverage rates than the northern Ghana region, which has the highest mortality as well. So this is a sort of interesting way to look at the data. You can, looking at by chart as well, you can maybe get a more clear picture of what each looks like. And again, you can select the data and different variables to look at where the poorest have the lowest coverage and the richest here do have the highest coverage. The other interventions we can maybe take a look at one per service delivery mode is if we go back to theme here, and we can collapse this view for family care practices, and we can look at preventive services. So for example, if we were looking at immunization, let me point out an intervention here, maybe DPT-3. It's a basic 3 doses of coverage. You can look at coverage by wealth quintile and again by region. So here we can see, this is what I've been talking about, in that the provincial level coverage, it seems high because here the national average is 89%, whereas what I showed you with the districts is, this is actually masking, so that information. So this is really why we need to go as deep as possible with the data to get further down subnationally as we possibly can to identify what the root issues are and which populations are affected. So moving on from this, we can also look at one more intervention in under, we can look under curative services. So for example, we can look at IMNCI, and let's look at ORS coverage. So for treatment of diarrhea, we can already see some trends among the different regions and which ones have highest coverage and which ones have lowest coverage. So it's interesting sort of view to look at. One other feature I'll quickly point out is with the map itself. So if we go back to, let's say, under 5 mortality rates, if we go back to sector and we select under 5 mortality rate, it should be here. Okay, we can do an indicator comparison. So to do that, what you'd need to do is, for the map settings, is to click on the gear icon and click on bubble overlay. So what this allows one to do is to select another indicator for comparison. So here we have under 5 mortality rate. It might be interesting to look at maybe as an intervention. We go back to theme. So this submenu you see here is the same as the submenu here on the left, just to give you sort of a second submenu to play with. We can look at, let's say, IMNCI and look at ORS coverage again, just for comparison's sake. So what you'll see is bubbles start to populate on the map. So what this shows you is, in terms of coverage and under 5 mortality rate, for example, if there's any correlation, or if there are some patterns that we can take a look at and glean that maybe with lower coverage there might contribute to higher mortality. So if you hover over the bubble, you'll get the name of the province as well as the coverage rates. And if you hover over the map, you'll get the under 5 mortality rate over the region itself. So it's just something for comparison's sake. We can change the underlying indicator as well. Let's maybe focus on diarrhea-related mortality. So let's go down to cause of under 5 mortality rate, diarrhea. Again, we may have to select the bubble and ORS. So it's making for an interesting picture where you can see that, I mean, with Ashanti, the coverage is very low, and it does have the higher mortality among the southern regions, and so does Volta, the lower coverage, whereas you have lower under 5 mortality rates attributed to diarrhea in Greater Accra with their coverage rates. So it's sort of an analysis for comparison's sake among indicators. Okay, so what we've mainly seen here on this dashboard is what's known as the situation analysis, and it's to give you a situational overview. And primarily, this is showing for you in terms of this module on EQUIST is just the data. It's just visualizing the data, which is just the initial step of EQUIST. You can also download all these visualizations and play around with them through, I think, JPEGs and PNGs, etc., PDF. But then you can do so with Excel as well. So you'll get, if you click that, you'll get a download version of the visualization and the data, the underlying data on Excel files. So you can play around with that data. What's been newer is country profile. So if you just wanted a snapshot of what the main core set of indicators are, interventions, demographics, mortality per age group, you can get that in one Excel file with all the data and all the visuals. So if you click that, it should download a file with all that information. One final, I think, menu that should be highlighted in the situation analysis is what's known as the frontiers. So there's a submenu that you can click on here called frontiers. So what this shows you on the left-hand side is our two benchmarks, the equity frontier and the operational frontier. Yesterday, we only spoke about the equity frontier, but I can just select that, and it might be easier to compare by wealth quintile. So if we select wealth quintile and order it from poorest to richest, this is what we can take a look at. So what this comes from is LIST, the LifeSave tool. So what this is looking at among all under fives, including newborns, which are the lighter colors here. We can also click them away if you just wanted to focus on post-neonatal, or if we can click away the post-neonatal if you wanted to focus on neonatal, is compared to your better off population. If you achieved the same levels of coverage as your better off population, how many deaths you could avert in your other populations. So in this case, we considered our better off population to be the wealthiest quintile. If you have another method of comparing or categorizing your better off population, that can be set up here as well. So if you put your benchmark for the wealthiest quintile as the best off having a certain coverage level, if you applied that same coverage level to the poorest 20% of the population, this is the amount of deaths you're looking at averting among neonates for these specific causes. So if we were to look at here, asphyxia, you're looking at 1,308 deaths averted. Among under fives, diarrhea, 545 deaths averted, and malaria, 392 deaths averted. And you can sort of compare and contrast this with the other quintiles. So this is just to give you a clear picture of the definition of an equity frontier. But if you were to look at this by region, in terms of each region, if they achieved the same levels of coverage as the wealthiest quintile, the wealthiest 20%, these are what they're looking at in terms of total deaths averted, if you add up the total causes, or by specific cause, you can take a look. So it just gives an additional layer to the analysis. The operational frontier, we use slightly less. And what this shows is compared to the a better off population, which is global, basically. So looking at the global population, they had conducted a Lancet study, which they had selected in terms of health service and health coverage, the top countries that had the highest levels of coverage and the best levels of coverage and the best care, how many deaths you're looking at averting. So among the poorest, you're looking at averting over 6,000 or so deaths, under 5 deaths amongst the poorest 20% of the population. Even the richest now, you can see, you're averting over 2,000 deaths by achieving those levels of coverage on the operational frontier. You can also look at this data, maternal mortality as well. So, for example, here we have, again, the poorest having by maternal mortality and maternal causes of deaths to specific amounts as well. And one final thing just to quickly point out is that you can also, if I go back to maybe under 5, it's easier to show. If we select package under disaggregation, instead of causes of death now, it's showing what healthcare packages are contributing to the highest amount of deaths averted. So here, this might give a health policy decision maker the idea that some certain packages may more likely should have a higher impact and maybe should be more invested in and resources allocated to in order to get a larger impact. And maybe through the equity frontier, you can look at if you're achieving the same coverage levels as the richest, how many deaths you're averting for each of these health packages. And again, feel free to click away any of the packages that you feel maybe are having lesser impact and just focus on the ones that you'd like to implement in country. So good. This covered the situation analysis, and I think you've taken a large look at the features. There are some customizability as well. So if you wanted to do a presentation and you wanted to adjust, let's say, the scale colors, you can do so by selecting the baseline color, which is the lowest, faintest color, and then the end line color, which is the highest, darkest color. So there's a bit of customizability there as well for presentation purposes, but I think otherwise the situation analysis is covered for EQUIST. And I think we're ready to move on to what we consider to be the most important module on EQUIST, which is the scenario analysis. This is where you'll be using your data now to actually go through a bottleneck analysis. If we select scenario, if on your screens, if you haven't generated any scenarios, you won't see anything here. It'll just be a blank screen with this submenu on the top here. On the left, you can select a data set. So I'm looking at Ghana. And I'm looking at Ghana 2014 as a data set. Why you see scenarios on my screen is because I had worked on these scenarios before, or I had been shared scenarios as well. And you'll see the name of the other user that had shared the scenario with me. What you'll also see are some details. So in terms of the scenario characteristics itself, you can see how the analysis was done, whether it was through geography, if it was by wealth quintile, if it was by residence, urban, rural. You can look at the start year, the end year of the scenario as well, which are shown just here. And if there's a description, for example, this was done for the Ghana Nutrition Strategic Plan, you can have maybe an idea. And I usually recommend people to enter a small description so that they can give some more details on the scenario. And if there was an impact generated, if there were results produced, because they could go along the 7-step process of developing a scenario and going through their bottleneck analysis, but stop midway. If they stop midway, there could be an X here, which means they hadn't produced any impact or generated any impact, but most of these have an impact generated. So what I can show you here is I can just step through how a scenario is created and how we use the data to actually undergo a bottleneck analysis. But before I step through the scenario analysis, do we have any questions on situation analysis? I know it's a lot to take in a short period of time.
I'm
Yes.
kind of counting on the fact that we will be able to watch it all.
Okay.
And
Okay.
redo it very,
Okay.
very slowly.
Okay.
And then we may email you with further
Sure,
questions.
sure.
But please go ahead if you have any
Sure.
questions now.
Very quickly, I'll just point out at the bottom, and it's always on the bottom if you log in, most of these buttons should be here. There is a user guide as well, and it's a lengthy file. It's a lengthy Word file which you can go through with a table of contents and click through a specific section. So if you do get stuck, that's a good starting point to take a look at. There's also a service desk. So if, just in case there are any bugs, and I should click on this to show you what that's like. So it takes you to a little bit of a different menu here. So you can put in what's known as a request, a service request. So if you click on a plus sign here, you create a new request. So you can either report a problem, suggest a new feature, or you can ask a question. And this goes straight to CSF Delhi Labs. And they respond very quickly, usually within the next working day or within the same day. And you can just give a little brief description here, or if you have any attachments, and you can send that over. In case there are any bugs or you feel there should be a feature that should be incorporated on the tool, then they will definitely respond to you and see how they can accommodate that request. Resources page is interesting as well. So the Narrowing the Gaps papers I was talking about yesterday are both located here as well. The Narrowing the Gap 2010 report and the 2017 report. And then there's the Tanahashi paper, which is used for the methodology for bottleneck analysis on EQUIST. There are some webinars that were conducted for different regions by UNICEF. And there is an EQUIST working paper as well that was, it was more of a formative assessment which looked at users and their feedback on the tool. And this is the pilot version of the tool, not the current version, and what enhancements needed to be made. And many of those were actually incorporated into this version of the tool based on that feedback from many different countries. There are a few other sources here and how EQUIST also has been used in the past. There's a GFF RMNCH investment case, and Robert, this might be interesting for you to look at, and how EQUIST was implemented from several different countries for GFF as well. I think beyond that, there's many other sources will be uploaded on here as they come along, especially for countries which have documentation which they'd like to share, anything that's shareable to the public in general. In terms of specific context within certain countries, other country focal points on EQUIST could reach this page and see if, based on their country context, if how EQUIST was applied elsewhere could apply to their country as well, and maybe learn similar lessons or take on similar analysis based on that. So this is just sort of an additional resource page that one can use. Yeah, sorry. So please feel free to ask any questions at this stage before scenario analysis. Any questions on situational? Yes.
Can I just ask one?
Sure.
First of all, I think it's an incredible platform. Just going back to the conflict between DHIS2 data and either CHERG model data or DHS data. I was just looking at, I was just wondering whether the system kind of flags up conflicts that appear in that. So for example, if you look at birth asphyxia in Ghana, CHERG says every region in Ghana has mortality from birth asphyxia, but then the DHIS2 facility data, lots of facilities reporting there's no instance of asphyxia complications.
Sure.
Does that sort of automatically flag up within the system as well?
So the thing is, this is something I'll show briefly when we get to the back end of the tool. So in terms of data entry, there's multiple ways of data entry on EQUIST. One is just through an Excel format, and that won't flag anything. This is just something that's an export from the tool that people can fill in and import back to the tool and automatically. But if you do data entry on the tool, there is actually a spreadsheet, and it's actually all the data sets for a specific country or a specific workspace, however you want to look at it. What it does flag is it brings up errors in terms of if the data within that data set doesn't make sense. At this stage, it doesn't look from data set to data set. It considers each data set separate. So for that, the user who's working on uploading the data and maybe I can touch base on that now, there are different roles on EQUIST. One major role is the workspace administrator. And that individual is in charge of publishing the data. So what you see on EQUIST, it's usually someone in country, someone senior. It could be a senior health strategist, it could be someone from the Ministry of Health, who's very data savvy, but doesn't necessarily have to do all the data work. They can assign what's known as data managers, and they can assign as many of them as they want to go through the data and validate the data, and actually go through the data sets and ensure that there is this a flow between the data sets, that it makes sense. In terms of the data within the data set, the system will look in and flag, once the data has been entered, any errors that with the data that doesn't make sense. So for example, let's say if exclusive breastfeeding is higher than predominant breastfeeding, let's say, which can never be the case, then it will flag that. So there are these commands built in, and there are these sort of proof rules that have been built in to ensure that the data itself within the data itself makes sense. But it's a good point that you're making, that the individuals who work on the data have to ensure that from data set to data set it makes sense. If they do publish it and they visually see, because it's so much easier to see the data and visualize it through the visualizations, that there are errors, they can go back in and readjust and publish it again as well. So there is a process behind the scenes. I can show you a little bit of that as well when we get to the back end a little bit. But for that, I think that would require a more involved session, I think. But it would be good for you to see, for sure. But that's a great question. Thank you. Is there any other questions about Robert? Yeah.
Thank you.
Yes.
Just to know what sources of data have been used to inform the district level in Ghana.
For Ghana, so what they use is their DHIS2, that's a great question, which they call DIMS, DHIMS. So where they get that data, that's facility level data. As you mentioned, it's taken from the facility. It's not representative of the entire district, though, just what's been recorded by the facility. So the quality of the data, and that's something maybe I could show as well. So they were achieving, and this is one important point, they were achieving higher rates of coverage than were possible for certain districts. They were achieving maybe 180% coverage of DPT-3 for many districts. And the reason why you'll see that is because you have populations from a neighboring district going to another district for some reason or another, if it's closer to them, even though they're in the neighboring district, or if there are better health services there, or it's cleaner, they go to a neighboring health facility, and it's not recorded where that patient came from. So if they're from the neighboring district, they get counted in the denominator of the population of the district with the health facility that they accessed services for. And so that's why you see really high coverage levels for certain districts and lower for other districts. So this is something we've communicated to Ghana Health Service. Ghana Health Service works alongside the Ministry of Health, but they're in charge of the DHIS2 data. And they produced the shape files for the districts you saw as well. So this is something that they said they'll be working on for the next year of data. So DHIS2 routine data gets uploaded and entered quite frequently from the country. It doesn't get updated on the tool automatically. Right now it's kept manual. You can see there's a lot of data for it to be manual, but I think at this stage they feel it's very sensitive, the data at this sense, and since it's government level data, they want to first adjusted at the back end and validated at the back end to make sure it's right. So for this data that's over 100%, we inform them that EQUIST cannot do an analysis on this data. It has to be capped at 100% because of list. So the LiveSave tool looks at data from data coverage from 0 to 100%. So if you're going beyond that, you'll get an error from list. List is, you'll see now, going to play a large part of scenario analysis because it provides modeling for deaths averted, stunting cases averted, wasting cases averted for different age groups, for under 5s, newborns, and mothers as well. So there's a lot of behind the scenes that you'll be familiarizing yourselves with as well. But in terms of the data, that's a good point about that you're making about routine data, is that the validity of it, I think, needs to be put in place before entry, and the country has to be in charge of that for their data. Yeah. And a workspace administrator in general, they sign a disclaimer before they're given that role, that they will be in charge of the accuracy of the data going in, as well as the new boundaries. Let's say if, like for example, Ghana will have 252 districts, so an additional 30 to 40 districts being formed this year, and a few more regions. Currently there's 10 regions, so they'll have 16, which they're planning for this year or next year. Yeah. Any additional questions, or shall we move to the scenario? You can, so what I'm going to bring you through is actually creating your own scenario. Okay. So you will be putting your own data in. No, it's okay. You don't have to be on Ghana. You can be on any country you want, by the way. So any data set, whatever you prefer. If you're interested in another country, feel free. So what you do, what I have here again is I have a list of scenarios, which you may not have, is to generate a new scenario. On the top right, you'll see this menu of icons that you can adjust your scenarios or create new scenarios. So what you want to do is click Add New Scenario, and then you can enter the details. So whichever, if it's a national health plan, if it's for an investment case, etc., you put in those details. And then, like I said, it's good to put in a description, and even for yourself, just so you can revert back and sort of more quickly figure out what exactly the scenario was that you developed. If you're looking maybe 5 years in the future, and you were looking at a scenario you've done, you'd like a bit more detail on that. And then you want to select the start date of the scenario, as well as the end date of the scenario. So if you're looking at a national health plan, it's a 5-year plan or it's a 3-year plan, you can set the dates right here, so that would be important. So by default, it's usually set at a 5-year plan, and this is all adjustable by you. Once you do put in this information, all you need to do is click Save. And what will happen automatically is that you'll be brought to the first step of the 7-step process, which follows the 7-step process for health system strengthening and bottleneck analysis through UNICEF. What you'll see before we go to that, again on the submenu, are these other icons. So you can, let's say, if you want to edit the details of a certain scenario, you can select it by clicking on a checkbox. So if I wanted to go to video demo, and let's say I didn't like the title or the details, again, you can adjust that and save, and it'll automatically make those edits and adjustments. Then there's deleting scenario. You just select a scenario and you can remove it if you don't want to keep it. Compare is something we'll look very soon at. It's comparing different results. So if you have an impact in cost from one scenario and you have an impact in cost from another scenario, you can make this comparison to see If you have a higher impact, what's contributing to that, or what's contributing to cost effectiveness. And it's a way for health policy program makers to take the best aspects of several scenarios and maybe make a different scenario where they take all the best aspects and achieve the highest impact at the lowest cost, so the best cost-effective scenarios, which is what's normally how this feature is being used for. Then there's also duplicate scenario, and what this is mainly used for is when it makes a copy of your scenario so that you can play around with. So if you have a scenario and you made all these selections, these are the interventions I want, these are the strategies, these are the cause of mortality I'm looking at. For that same population, you'll generate the same scenario, but can make slight adjustments on the second scenario and see what impact that has. So it's a quicker way, instead of starting over from scratch to from step 1 to 7, going through that process again. You have it there and just make these adjustments at later steps. And then there is share scenarios. So I can pick one of you to receive this scenario. Maybe Robert, I can share you this video demo for Ghana. So if I just type in your name. Robert, what's your surname? Sorry.
Kargugu.
Kargugu. There you go.
That's it.
There you go. So you should receive it literally in 2 seconds or so. If you hit enter, you may have to refresh the page.
This is
it will be there.
All right. Wonderful.
So what that's used for, and you'll see that it's going to be shared by my name. So what this is used for is when you have a group of users, and let's say you have within a country user group, what you can do is just immediately share scenarios and say, you have a good impact, but your cost effectiveness is not what it should be. Here's how I may have a slightly less impact, but I have a much higher cost effectiveness. Let's see how we can take the best elements from both these scenarios and create a better impact with the lowest cost. So this is what it's primarily used for. And many countries just form groups and they sort of use these features. It's interesting to play around with. And the final, I think one of the more important, the last submenu item is the download of the scenario. So you can download on an Excel file all the selections you made in one snapshot. And I'll look at this, I think, at the very end with you, because this shows the results, and this is mainly what people do to show images and data, and in terms of mortality rates and modeled deaths averted and causes of stunting and wasting averted, what the impact has been. And so this is one of the, I think, major features. Mm-hmm. And I think in general, most people feel this is their favorite. It's the most complicated module on EQUIST, but it produces a lot of impact, so it's good to see. Mm-hmm. So when you do generate your new scenario, once you've clicked here and added all these details, what you'll end up seeing automatically after you click, on the save icon, is you'll jump straight into the scenario just after clicking save. You'll be at step 1. You'll see here the 7-step process on EQUIST. So selecting your priority population, which populations are the most vulnerable that you want to focus your analysis on. Or you can even look at the situation nationally, however you want to do your analysis. What we call the focus area. So these are causes of mortality and morbidity among your selected population. Interventions, so how to address these causes of morbidity or mortality, which implementations will be more effective. Bottlenecks, which are preventing your interventions from being implemented successfully. And this is actually looking at which bottlenecks determinants should be prioritized. The root causes of bottlenecks, this is looking deeper within your population. What are the main reasons behind these bottlenecks? How should we address these bottlenecks? Strategies, so these are bottleneck reduction strategies on how to overcome the bottlenecks. So which strategies would best be put in place contextually? And this is what I showed you yesterday with the effect sizes, which strategies had better effect sizes or more relevance in reducing certain bottlenecks within the population selected. And then what you do is through LIST, the LiveSave tool, and the MBB, the marginal budgeting bottlenecks tool for the costing, you'll get a modeled impact and cost and your results, which you can take a look at. So what you'll see here, all the way back to step 1, is your selections here impact the rest of the analysis, because what you're selecting here is your target population. So what you'll see in the remaining steps once you selected your target population is the data reflecting the population you select in step 1. So if you select national population, it'll reflect for the remaining steps. If you select just one region like Volta for Ghana, you'll see that data is reflected for that one region for the rest of the bottleneck analysis. So what you're seeing here now in step 1 is what's known as the drivers of inequity. Now what this is, you don't have to make any selections on this tab here, the identifying driver of inequity. This is just to give you or make you take a look at how you want to sort of formulate your analysis. So looking at, let's say, under 5 mortality rate, what we have here in the top, analysis by. If you click this, you'll see the same indicator list as we did in situation analysis. It's set up the exact same way. You have sector with the indicators, demographics, epidemiological parameters, which you can expand and select different indicators to reflect the data, and theme, which are interventions as well. So this is just, again, for you, it's similar to the situation analysis to formulate how you want to do your analysis. And you can select the unit to be number or rate. So if we're looking at under 5 mortality rate, for example, we're looking at deaths per 1,000 live births. You can see that the circles here are looking at different regions of Ghana. So if we're doing a regional level analysis, we're looking at, let's say, the regions with the highest under 5 mortality rate, which here you can highlight as northern, as we saw, and then upper west and Ashanti. And those are the highest under 5 mortality rates. If you're looking at urban versus rural, you can take a look at that as well if you want to do your analysis by urban and rural settings, or by quintile. So here we can see again, and this is something that Professor Igor was also noting with situation analysis, is that quintile 4 and 3 have a higher, according to the data, higher under 5 mortality rate compared to the richest. So you can look at it this way, or by total number of deaths. It's very similar to how we saw in situation analysis, but it's just to show you between the lowest mortality and the highest mortality, if I show it by rate, lowest to highest, how much of a gap there is. So it's showing you in this sense that through these equiplots that there's this much of a gap in mortality, and this is maybe a focus for your analysis moving forward. The other tab is now where you start making selections for step 1. So if you set your target population, so what you'll get here now is a map, a small map, and all the regions listed here. If these were the districts, if we selected the district data set, then you'd see all the districts listed on the map, and a list of districts here. You can organize this data again alphabetically, or what I tend to prefer, which is easier for me, is under 5 mortality rate highest to lowest going down. So then I can immediately see, oh, those are the regions maybe I need to focus on, and make those selections. So based on and depending on your analysis, you can make those selections. If you prefer to make the selections, you can select them on the check boxes on the left-hand side, or if you click directly on the region of the map, they also check on the boxes automatically. So if we go to this submenu as well, you can change how you want to do your analysis. So if you say, maybe I'd like to look at my bottleneck analysis by wealth. So you have the data here as well, and you select maybe the poorest 20% that you want to focus your analysis on, or the top 2, the poorest 2 quintiles as well. And one additional feature that you can see is I've selected here Ashanti and Northern regions. There's what we call this donut chart on the right-hand side. And I would mainly focus on the proportion of total burden, as this is much simpler to understand. What you can see here is if you start clicking in the population, the other regions, is especially with the higher under 5 mortality rates. Let me order it again. You'll see that the donut chart on the top right there is starting to fill up more and more. If you selected all the regions, it would be at 100%. So what does this donut look at? It looks at, based on the populations you selected, the percent contribution to neonatal deaths and total number of neonatal deaths on the top right-hand quadrant here. And the outer layer is in terms of total neonatal deaths of the entire country, of all of Ghana. So how much this population you selected contributes to neonatal mortality. If you look at the bottom quadrant here, or it's not called quadrant because it's not 4, but it's a bottom section of the donut, is contributing to 68% of under 5 mortality. So these 6 regions are contributing to 68% out of the total 100% of the entire country. And then you've got the same for maternal as well on the top left section of the donut. So once you've made your selections, whichever regions you feel are the most deprived, let's say, or the most vulnerable, or how you want to do your analysis. Again, you can just click select all if you want to look at everything together. You can just click save on the top left. So after you adjust every step, they ask you to click save, and it's usually blinking like that, so you can proceed to the following step. You can see the rest of the steps are grayed out because I made some selections, and what it's going to do is once I click save, the data for these 6 regions will be reflected in the remaining steps. Going forward, yes?
You can choose maybe wealth, or you can choose either together?
You can choose those, yeah.
Okay.
And then the data will reflect those as well, or urban or rural, however you want to do your analysis.
So you can still choose that.
Yeah, yeah. And that's what the drivers of inequity are, is to give you an idea how you want to do your analysis by looking at those gaps. Is urban much lower in terms of under 5 mortality rate and rural in this case? Or do you want to, is it you find that the regions are more interesting to look at? So we normally look at the regions just because they want to see how they want to allocate their resources, but if they want to go to do further analysis, they can look at wealth quintile or region, or other variables. There are male and female for certain countries, so you can look at gender, and then there's also a mother's education that one can look at. If the data is there and available in the survey, then they can definitely capture that. So I'm actually not going to save this because I don't want to adjust this video demo, but I'll move on to step 2. So when you're on step 2's landing page, what you'll see is the focal areas. So what these are normally are the causes of mortality and morbidity. We had previously had this as epidemiological parameters, but adjusted it to focal areas mainly because we're in the process of incorporating adolescent health as a theme onto EQUIST. And there you're not necessarily looking at mortality, you're looking at a number of other different outputs as well, and child protection, for example, and mental health. So if you look at the different tabs when you click when you save and move on to step 2, you'll see a breakdown of causes of mortality and whether the unit is a number or a rate. So here, what you're automatically given is a tree chart, and this is mainly available for number of deaths, just to show you what the top maybe 5 or 6 or however so many total number of neonatal deaths are, or post-neonatal, if I click on that tab, what those causes are. If you hover over, you'll get the total number of under 5 deaths in this target population. And if you click on one, like malaria, to sort of look at in your analysis, you can click it and it'll come out as dark blue, like these selections that were made for neonatal mortality. If you want to look at it as rates, you can do so as well. So it's again the same list of indicators or causes of mortality, morbidity with their under 5, with their specific rates or contribution to mortality. So here we're looking at, let's say, asphyxia contributing 10.5%. And prematurity to 11.4%. If we click on post-neonatal, you can also make selections this way and maybe focus on, let's say, malaria, pneumonia, diarrhea, the top causes of mortality. Child nutrition, we can look at stunting and wasting. So this should have shown up for the others, but it could be because of some data issues. But you see this blue chart, which is this blue line bar, which is available on the other charts as well. What that's looking at is among the population you selected in step 1. This is what the mortality rate associated with this cause is, or stunting due to this cause is in this specific case, or wasting or whatever cause you're looking at. So this is looking at 22.3% stunting, 23% stunting rate through all these causes. What this green shading is here is among the least deprived. So what's been set up as the least deprived for this workspace, what the stunting rate is. So what this setup is for, what this visualization is for comparability. So among your population, what's the stunting rate or the wasting rate or the mortality rate from that specific cause compared to the better off. So the better off population that's been selected for this analysis, that's been set up by the country, is the wealthiest quintile, is the wealthiest 20% of the population. So it's for comparability sake. And again, you'll have the same for maternal mortality in terms of the data, what the rates of the contribution of this cause to mortality is. So here is where you make selections by clicking on the, let's say, the causes of mortality. This just gives you sort of a frame on where which cause of mortality you want to address within your target population. So again, during situation analysis, you identify these causes of mortality. Here you select them. So this, again, scenario analysis is where you make your selections through the 7-step process. Once everyone's made those selections, again, you can click Save and move on to step 3. Step 3, again, you'll see on the landing page a tree map with the the number of excess child deaths that could be averted by implementation of these interventions. So this is slightly different of a tree map from what you've seen in the previous step. This is looking at how impactful these interventions can be in addressing mortality. We're looking at this by number, but you can look at through these 3 service delivery mode tabs. Again, the same setup of the interventions that were pointed out previously, the rate, where you'll get this list view. And here again, what you're looking at, the blue charts, the blue bars are the coverage rates of each of these interventions among the population you selected in step 1. So I selected a few provinces, and this is what the data is reflecting. And it's looking at the coverage rates among your population versus, again, the better off population or least deprived population, which has been set up, which is the wealthiest quintile. So here, for example, improved sanitation among the wealthiest quintile is at 40%, compared to the 22% among your selected population. So it's just looking at coverage in general, and you can look at this for all the interventions that have been set up on EQUIST. And you can, here's where you make selections by clicking on the name of the interventions which you'd like to do your analysis on. So what you're going to do is when you make your selections of interventions, these will apply to steps 4, 5, 6, 7. And what happens there is when you make a selection of an intervention, you can actually go through and do your bottleneck analysis, as you'll see, for each of these interventions. So it's good to focus and select more interventions maybe than you can even need for your analysis. If you want to do a broader analysis and look at a higher selection of interventions, you can decide not to make any adjustments to any to some of the interventions, but it's just to have a look at, and that's something we can see as well moving along to step 4. So what you want to try and do in this step is to try and address your cause of mortality, select the interventions that are most relevant to addressing that cause of mortality and morbidity. And again, once you've made your selections, let's say if you've gone through all the service delivery modes, and they're also categorized by health package with the green headings as you go down. So under curative services, you have IMCI interventions on the top. And you've got skilled birth attendants delivered by a skilled professional, and EMONC, emergency obstetric and newborn care for complications at birth. You can, for example, in step 2, if you had selected that diarrhea was one of your focal areas to address cause of mortality, you could select ORS depending on, if there's higher inequity between the, let's say, less deprived, the population that's considered the least deprived, which is the richest 20%, and your selected population, which is what we consider the target population. Once you've made your selections, you can click Save and move on to step 4. So now, all the selections the interventions you had selected in step 3 will show up on these sub-menus here. So again, if I clicked on the left-hand side menu, we have the 3 service delivery modes. And for each intervention we selected, so for example, we did select a wash package intervention. And the specific intervention we looked at was safe disposal of child feces. So what you'll see here now is looking similar to the Tanahashi model, which is looking at the determinant approach. And as I showed yesterday, what one can do is they should map indicators to each of these determinants. What's set up here, normally if you generate a new scenario, are defaults. So the country can go in and set up these defaults, which indicator should be there for which determinant. So your determinants reflect let's say your supply and demand bottlenecks. What is causing, what is impeding your intervention from being implemented effectively? So on your top left-hand side here, you'll see availability of commodities with an indicator that should be assigned to it for what should reflect best availability of commodities. And maybe I can choose maybe an intervention that would best reflect this. If I go to preventive antenatal care and tetanus toxoid vaccination, as an example, here we could ask, is there enough tetanus toxoid vaccination that's available in the health facility, and why or why not? And a good indicator would reflect that. So when you select an indicator, you can adjust this. So there are marker icons. So if you take a click on one, you might see some proxy indicators if there is no standard indicator available. If there is a standard indicator available and you don't see it on the tool, it can be set up as a default on the back by the workspace administrator. or you can, as a regular user, you can set up whichever indicator you'd like here, put in your source, and adjust the coverage value by clicking on the slider and moving it around. And it's good to do this process for all the interventions that you've selected for your analysis. So, for example, availability of human resources, for this specific data set, they didn't have that information, but if you did, you can go in and if you had a good indicator to use for that, you can enter that. So, for example, facilities with staff trained for ANC, that would be probably a good indicator to use in this case. And if you'd have the data, you can adjust that slider. So this is again looking at availability of commodities, human resources, geographical accessibility, financial affordability, social-cultural acceptability, the supply and demand determinants that impact whether the mother is actually accessing the health facility. So it's showing that among the population you selected, the specific regions, there's a 96% initial utilization. So many mothers are accessing health facilities for antenatal care. And again, an indicator that's shown for this is ANC 1+, which is our mothers getting at least one visit to the antenatal care facility. So it's the initial utilization to the health facility. Then there's the continuity determinant, adequate coverage. Is a mother returning for care, or this might be a bottleneck. Looking at if, let's say, the HR is not good, the human resources, the health services are not of higher quality. Are they coming back or not? Or what's stopping them from coming back? Is it too large distance from the health facility, or what are the major bottlenecks in this case? So you can see it's slightly lower, and the indicator selected for this was ANC 4+. Are the mothers getting at least 4 more visits to receive antenatal care services? And then the quality intervention is usually the same intervention as the title is effective coverage, looking at our mothers, pregnant women receiving at least 2 tetanus toxoid vaccinations, a full quality of care, which is what we want to try and bring up by addressing all the determinants. What you see on the right-hand side is severity, so it's a traffic light system, and you have a scale here. So what this system, this is, you can decide to follow this or not. What this is showing for the health policy decision maker and planner is to look at how severe on the spectrum these determinants are considered based on the coverage levels of the indicator that's best reflecting them. So again, this is one feature that one might follow, but one might not, because they didn't have any human resource data to show here. This will come out as red because it's showing it as 0. So that's something that they'd have to map initially, and then select whether any of these determinants are priorities or not. So the goal here in this specific step is twofold, is to go through all the interventions selected in step 3, which will show up here. You can decide to skip ones if you feel you don't want to implement those interventions later on. That's fine. And is to select which are the priority determinants that should be addressed, which are the root causes of bottlenecks that should be identified going through this step. What you'll notice is that there's this sort of cascade effect between initial utilization, adequate coverage, and effective coverage. And it should always follow this similar trend because so the indicators representing initialization, adequate coverage, and effective coverage should follow this cascade. It's okay if initial utilization, adequate coverage are equal, or if adequate coverage and effective coverage are equal. But the reason is the indicators that best represent initial utilization should show that the person accessing the service, this is the initial, that they're actually accessing the service to begin with. Adequate coverage, are they receiving continuity, which is always either the same or lower. It can never be higher. And the same with effective coverage. Are they accessing Are they receiving continual treatment, and are they achieving the best quality of care? So this is what we're trying to increase as much as possible through our analysis to bring the coverage levels up for this intervention for tetanus toxoid. So this intervention was 2 or more doses, as we had seen. So for this specific intervention, we had selected the following determinants, which we considered to be the higher priority or more severe bottlenecks, which were for geographical accessibility among the populations you selected, financial affordability, socio-cultural acceptability, and quality as well. So one quick note here is you might ask how these were selected. And that's mainly through discussions with our country counterparts and with the Ministry of Health. They're involved, they have different focal points that come in, and they take a look at, let's say, the population that they have the most experience with or have worked with, and they have a good idea of what the major issues are within that context. And that's really why we have these in-country workshops, to get their input on what the major issues are. And then they go through the mapping of the indicators to determinants as well. They can do this from the front end here, or by the workspace administrator on the back end. They can set up as default, so it's automatically there when they generate a new scenario. But this is a very important step to move forward and identify where the more severe populations determinants are.
In this
Yes.
case, the human resources one, is there no data available?
Yeah, for this,
That shows the highest severity. So
Yeah,
that's 0, that's why it's red.
so this one is actually misleading in this case because there's no data available. So they left this out because they just didn't have an indicator that would properly reflect it. You can use a proxy indicator. You could use a composite indicator as well. But in this case, they didn't have any of that data available. So if they do, they can input it just here. And this color will update. So if we were to select facilities with staff trained for A and C, and we were supposed to put in the source, and let's say it's a DHS, and it's 2014. If they did have it, let's say they had 50% coverage level, 52%. Now you can see that the severity has been updated, reflecting the coverage level for that indicator. Yeah, and then they can decide to select or not. Yes, Robert?
I understand the relationship between the 3 last determinants.
Sorry, I'll just navigate back to that. Yes.
So I'm saying that I can understand the relationship between the 3 last determinants.
Yes.
But can we have a relationship between, availability of human resources and the following determinants?
Geographical?
Yeah.
So these, all 5 of these determinants, all contribute to initial utilization, because it's looking at, these are basically impeding determinants that could decide whether the mother does or does not access the health facility, in this case for antenatal care. So each of these could be reasons why she's not going, the coverage levels of these. So these, the way it's set up, are not interrelated amongst each other, but all contribute to initial utilization. So if initial utilization, if these are at lower levels, initial utilization would go down, and so would adequate coverage and effective coverage proportionally as well, accordingly to these top 5 supply and demand determinants. Yeah. At the bottom, I also showed this yesterday, is the enabling environment. If you expand that at the bottom right, this does not contribute to your output, but it's additional details you can look at for what's considered priority in terms of bottlenecks among your enabling environments, looking at social norms, legislation, policy, budget expenditure, and management coordination. So it's just additional details which you can select, but it has no contribution at this stage to the analysis in this version of EQUIST. I think they're working out how to piece this together on how it can contribute to the analysis in general. But it was important to include this level of detail just so countries as well have found it interesting to use, especially with legislation and policy, to see where bottlenecks may lie as well, and just to provide that additional layer to the analysis. Beyond that, once you've made your selection, so you can go from intervention to intervention. So if I were to go to curative services and delivery by skilled professional, and I went to clean birth practices, again, I can do the same thing. What I just wanted to show to you, this cascade effect. So what if I were to put an inappropriate indicator, so maybe an indicator that has a higher coverage level than the initial utilization, which wouldn't make sense if I put it at 89. So what you'll see automatically at the top is inconsistent coverage values. Because you have this sort of, I call it a roller coaster, but it's a non-cascade where you have your continuity of care is higher than your initial utilization, which wouldn't make sense in terms of your determinants that we're looking at. So that's something you'd have to go back into and maybe select a more appropriate indicator. And this is something we tell the countries as they go through this mapping process. And this is done for all the interventions selected. So moving on to step 5, sorry, I didn't want to save that. So going to step 5, you can again, at the top, you'll have your service delivery mode and the health package and the interventions you selected back in step 3. So what you're doing here on this step is, let's say, one note I forgot to make if you go back to step 4, 5, or 6, is that you can make adjustments even by the package. And what it does is it applies these, let's say if you identified specific high priority bottlenecks, you can apply these same selections to all of the interventions in the package by just making these selections at the package level. So let's say for WASH, if I had certain interventions, I can just make these selections and it will apply. And that goes the same for steps 4, 5, and 6. So in step 5, here is where we're looking at the specific root causes of the bottlenecks. So what you'll have here is actually all the determinants, and you can see they're highlighted by their severity. So, but just like back in step 4, availability was considered middle severity, and here it's showing it again, middle severity. What you'll see next to the determinant is whether you selected it as a priority or not, if it's a priority severe strategy or not, a severe bottleneck or not. We still kept the other determinants as well. As you can see, even though it was not selected, later on the user might decide that insufficient access is a problem, insufficient access for human resources, that they may still select it as an issue, as a root cause of bottleneck for the analysis. So this is just something to help make their selections on. And they can provide details for each of these root causes of bottlenecks, as specifically within your population, what are these causes of bottlenecks? So if you're sharing this scenario with another user, then they can, instead of asking you, like, why did you select this, you can make that very clear in your comments and justification. So this is broken down again by availability, accessibility. We're looking at affordability, for example. It's showing it as higher severity bottleneck. And they identified that both direct financial barriers and indirect financial barriers are both root causes of bottlenecks. Specifically, direct financial barriers could be the mother just can't afford to have antenatal care, and indirect could be she couldn't afford transportation to get to the health facility, so it's a more indirect financial cost. And they can justify that again here as well. And so this would be done mainly for each of the determinants that you've selected that have the check marks, but they seem to have gone beyond and selected also additional causes of bottlenecks. And again, you would do this for each of the interventions specifically. So just going through one by one. And once you're done with this process, you can click Save and move on to the next step, which is step 6. And again, for the final time, you'll see this submenu with the interventions that you've selected back in step 3. And now, based on your selections in step 5, the cause of interventions, you'll see this relevance scale. So whatever you clicked on step 5 as the root causes of bottlenecks, so going back again here, they didn't seem to have selected anything. So you'll see in step 6 that the relevance of these bottleneck reduction strategies to reduce the bottlenecks are all red because there are no selections made. But since we made selections for WASH, if we go back to family care practices, WASH, and safe disposal of stools, then you'll see some more relevant strategies that could apply based on global evidence to address those bottlenecks, the specific root causes of bottlenecks. So on the left-hand side, you have the scale with the higher relevant strategies that would be more impactful, let's say, standing out, and the lower strategies, lower-end strategies being in red. You can customize and, let's say, create a strategy here that's not available on this list, and you can actually do that also for causes of bottlenecks. You can select an other cause of, let's say, inadequate coverage, and specifically state what that is in case that's not available from any of these lists. So this is just to give an added contextualization to the analysis. What you'll see is under your effect sizes here, how impactful these strategies are to addressing your bottlenecks. And so what they've selected is supply side financial incentives would address their financial bottlenecks, so their direct financial barriers to access this health service. So it could be within this range. They have orange ranges for each of the strategies coming from global evidence. And within these ranges, this gives an idea of what the global evidence is showing. You can go beyond these ranges as well, because your population that you're focusing on would be obviously and mainly different probably from the global evidence as well. So you're free to go beyond. You'll get a little red marker, and I can show that as well if you go beyond the ranges. It's just showing you, I think if you hover over it, that the effect size is beyond the suggested range. The suggested range is based on global evidence, but you're free to go beyond that, and it's fine to leave it like that because the global evidence is not applicable to all subnational areas, and you should, if you have effect sizes, definitely apply them to each of these strategies as well to show within your population how impactful these strategies are actually. Or you can rely on these ranges, whichever you're more comfortable with. How these are set up, these strategies are financial strategies as can be seen here. Service delivery strategies, these are looking at service integration, rehabilitation of facilities, quality improvement, community education outreach, and emergency access interventions, as well as community health workers service delivery. And again, you can create your own that may not be listed above. And then there's strategies under medical products, vaccines, and technologies. So it's looking at pharmaceutical regulations and stock management, and ensuring availability of equipment and key commodities. And then there's your human resources here. So looking at in-service training, task shifting. If you have maybe not enough, let's say, human resources or health staff in one health facility, you can assign and train, let's say, other roles to take on roles of maybe specialists. So maybe if you have physicians specializing in certain roles, they can be trained on other roles to cover maybe a specific lack of service, and looking at enhanced supervision and leadership and management training. Then we're looking at governance leadership, looking at health system accountability, and then looking at information, looking at health information system strengthening and data strengthening, especially the quality of the data, as well as patient reminders. So when going through this, one should select a strategy that they wish to implement, usually one that has high relevance. This traffic light system will show you the relevance of the strategy to the intervention that you're selecting. And this color scheme comes from your selections in step 5, which you selected are the main root causes of the bottlenecks. So here, for example, for supply side financial incentives, one can adjust their effect size within the orange range, which is coming from global evidence, or they could even go outside. You'll get a small red marker here if you go outside the global evidence. This is just telling you you're going outside the global evidence. But if you're looking at specifically a context within Ghana, you can it may not follow the global evidence, so you can adjust the slider beyond that. And to sort of customize this further, let's say you've moved your slider to 73%. You can actually click on a side pen and note tab. What you'll get is a way to adjust the impact of your strategy per determinant. So if this has more of an effect on financial affordability, you can readjust your 50% that you assigned effect size and redistribute that to maybe more so to financial affordability. And if it improves your intervention, and let's say if it improves knowledge on or the practice of safe disposal of stool, then you can actually improve your effective coverage, which in large part is what has contributes to your improvements in coverage of this intervention that we're looking at. So let's redistribute this 50% to more so towards financial affordability and effective coverage. Let's make socio-cultural acceptability, let's say it's not that impactful on socio-cultural acceptability. Let's make that 0. Let's make commodity 0 and human resources 0, and just focus on these 2 determinants that this strategy has a large impact on. So let's say amongst the 50%, it would have 15% financial affordability contribution and 35% to effective coverage. So if you do that, if you move and redistribute your impact, you can see that we're back at 50. If I click outside, 48. Oh, sorry, this should be 15. And if you just click X, that will apply. And how you can see if this has applied on your effective coverage is if you click this, they call it a hamburger icon. If you click on that, you can see a slight impact on your effective coverage. So your effective coverage, which is safe disposal of stools, has gone up slightly from your baseline. It's gone from 22% to 25%. So by 3% over this 5-year period that we've selected back in the creation of the scenario, just from this one strategy of supply side incentives, let's say. And so what one should do is, again, go intervention by intervention And it's helpful to go through this level of detail, going in with a specific strategy, selecting it, and going through the distribution to ensure that your effect size is allocated most realistically within your population so that you do get an impact. And once you've made your selections, you'll click Save to go on to the final step. So what I'll do is I'll sort of cheat a bit, because in step 7, what you need to do is select Estimate Impact List. And what it does is all the selections you made in steps 1 through 6 get sent to a server at Johns Hopkins through the list tool. And it's usually, maybe depending on your internet connection and depending on how many people have clicked this at the same time, it may take a little while, but it can take anywhere ranging from 3 to 5 minutes to generate the impact and cost. Sometimes the cost doesn't come up right away. You have to refresh the page and it'll come. But what you can do is you can take a look at your target coverage in the meanwhile. Which is this tab here. And what this is looking at is if you, based on the selections you made, how much of an impact you're having in terms of improvements in coverage. So if you're looking at baseline, this dark blue bar, it's your baseline data showed that improved sanitation was 22%, but since we're addressing sanitation within the scenario, we've brought it up to 50%, so doubled it over a 5-year period. So this is just for you to have a check, to go through and check based on your selections made, how much improvements you've had in terms of your intervention coverage. And you can look at this by the packages, which is what's shown here. What you can do, and this is not to do for the analysis, but something maybe as a comparison, is you could artificially expand some of these coverage levels. You could type in this as, let's say, 50 or 60, and just to see what impact that has. So normally what I do is use that as a comparison. So if I put in, let's say, target levels for the SDGs or whatever for each of these interventions, I can put in those figures here at endline. And generate a second scenario for comparison's sake. So to look at how many deaths would be averted in one scenario in the best possible case if you achieve those targets, compared to realistically what we're looking at. So it's sort of an interesting way to look at how far you'd have to go and how much you'd have to invest to reach those levels. So once you've clicked your Estimate Impact List and it's run successfully, you can look at the impact in this tab, Impact tab. So now what you'll see are 3 charts immediately. At the bottom of these 3 charts, you'll see the regions you selected. I've only selected Ashanti region and Ghana region, Northern Ghana region. And I mainly focused on neonatal mortality in my analysis specifically. So for asphyxia, I was able to, in my scenario, which is this 3rd bar chart on the right-hand side, I was able to avert 476, it says under 5 deaths, but neonatal deaths are fitting within that category still. And 13 tetanus-related deaths and 55 prematurity-related deaths. I've only selected a few interventions, so we'd have not that much impact in general. What the equity frontier is, and as I've mentioned before, the definition of the equity frontier is looking at is if you achieve the same levels of coverage as the better off or the least deprived population, which is the wealthiest 20%, this is the expected impact you're looking at achieving amongst your population, what you've selected back in step 1. So if the better off population, if we achieve their levels of coverage, you'd be looking at even double. So not 476 asphyxia deaths averted, but 1,132 asphyxia deaths averted if you achieve their coverage levels. The operational frontier, the first bar chart, is looking at comparison globally to the best performing countries, according to the Lancet publication, on the best health services and coverage levels. Asphyxia is now 1,808 deaths averted. If you achieve the same levels of coverage to address asphyxia as your in your population here. So these are, again, by causes of mortality. We can look at this by package. So you can look at health package to see which packages are more impactful in terms of addressing mortality. What you can tend to do here is you can also look at the operational frontier just to see how they're doing it, how they're getting high rates of mortality addressed in general from their provision of services. So here it's just showing EMONC is contributing to 2,300, a little slightly over deaths averted. So it's sort of to give that number. You can also look at this number of deaths averted or the rate. So if there's been a reduction in under 5 mortality rate, if we select that, and by how much. So with asphyxia, it's saying it's a reduction of 3 deaths per 1,000 live births in my scenario, specifically. Again, also one other thing is you can, if you worked on maternal mortality or neonatal mortality, you can maybe only focus on those causes and how much impact you're having there. If you worked on nutrition, you can have how many malnutrition cases were averted. So here, I didn't work at nutrition interventions at all, but here's, again, in the same format, it would give you how many stunting, wasting cases you've averted. Stunting cases and reduction in wasting rate, as well as number of anemia cases averted. And then in terms of cost, you're looking here at, in terms of, as I pointed out yesterday, how your costs have been allocated. And again, these are marginal costs. These are not exact, precise costs as you could get from the One Health tool if you put in more detailed costing data. They did put in costing data here, but it's showing starting from baseline 0 the marginal costs and the breakdown of these costs per strategy that you had selected within step 6. If you look at the middle chart, you're looking at the cost effectiveness. So here it's showing that only 900 deaths are being averted per 1 million US dollars spent, or number of lives saved per 1 million US dollars spent. And the cost per capita, which is approximately saying it's slightly over 1 cent. So it's less than $1, but it's still within reasonable cost per person. And so here's where you have usually your results displayed. You can, if you click back on the scenario tab just here, you can have your list of scenarios again. Now if you want, you can choose to display all the selections you made by clicking download, this little icon here. So it's going to send to me an Excel file which I can open, and which can display by each step 1 through 7, what selections I had made, and even further than that, it can show basically improvements in coverage by intervention. I'll quickly step through that, and then I can just show a little bit of the back end of EQUIST, maybe for 5 minutes,
Yep.
and then we can, I think, close there for questions.
Okay.
So this is what I find fairly useful, this Excel file, once it opens.
Please, by all means, yes.
This is what, I don't know if you had gone through this, Robert, but this is looking specifically at all the selections you've made during your entire analysis. So what you have here are your 7 steps, and you can choose to expand any and each of these steps just to see all the selections you've made throughout the entire analysis. So we selected for our focal areas for those 2 regions, asphyxia, congenital anomalies, prematurity, interventions that we looked at. There's one among WASH, safe disposal of stools, tetanus toxoid, folic acid supplementation, IMNCI, skilled birth attendance, and EMONC. We have a longer list among EMONC interventions since we're addressing neonates. And looking at the bottlenecks here, how you read this is, so it's a larger chart. Maybe I can zoom out a bit. So what you can see here on the left-hand side are your health packages and interventions selected back in step 3, and then each of your determinants. There's a color scale for how severe the determinant is. And here is the X's are showing which specific determinants you had selected for each intervention. And then scrolling down, this is just so you have a snapshot of all your selections on one file, on one page, is the root causes of the bottlenecks and which selections we had made. So just for demonstration purposes, we had only looked at 2 interventions specifically, and we had selected specific root causes of bottlenecks in this summary page. And if you look at strategies, it's very similar. If we go back to step 6 now, what you have on the left, again, are your same interventions by health package and your selections of your specific strategies that you're using. The colors are showing you the relevance of your strategy. So looking at if these strategies are relevant to addressing your bottlenecks in step 4 and 5. So if we scroll down, we can see that we selected a few strategies for addressing clean birth practices, and we focused more on service delivery, so service integration, building rehabilitation, new facilities. Maybe that was an issue, a lack of health facilities within the proximity of the populations, and quality improvements, improvement of quality of clean birth practices to ensure that that's made more available and more practiced within facilities. So as you can see, many of these strategies are also fairly, standard practices, and they may, if they're not implemented in country, or there's lack of belief or sociocultural acceptability or affordability for some simple standards of care, then it could lead to this impact of mortality. And you can even achieve a higher impact with just simple strategies. You don't have to invest in higher end strategies to address these causes of mortalities. In some cases, you can actually get quite a large impact from these simpler strategies. And finally, looking at the results, so the impact in terms of your analysis. Here you can get the breakdown. So in terms of neonatal mortality, how many deaths you're averting. If you move the image, the chart out of the way, if you move it to the side, you can look at the data in the back end. So you can see how many deaths are being averted overall. So here among neonates, we're getting a total number of 562 deaths averted, and the breakdown by cause. So the highest is showing 476 due to asphyxia being averted. We can also look at, in terms of under 5 mortality, the breakdown of your impact there by shifting the chart and seeing the data. So again, since neonates are within the category of under 5s, you can still see our focus was on neonates. We didn't make any adjustment to post-neonatal care or strategies. So that's why you don't see any impact there. And then the same for maternal mortality. So in terms of cause of maternal mortality, we do have an impact, and it's mostly through antepartum hemorrhage that we're looking at. We don't have any impact on stunting or wasting because we didn't focus on nutrition. So those will be blank, but if you did, they will be populated with the operational equity and your scenario impacts. But for under fives, what you do have also is how impactful the strategies are in reduction of mortality. So it's showing that in my scenario that delivery by skilled professional contributed to the 452 or 3 deaths averted, and you can see the breakdown of the health packages here as well. And scrolling down further, we have the cost, the impact by cost as well. So here you'll get those same 3 charts if I zoom out a bit. So looking at your allocation of costs among your strategies, your cost effectiveness, so deaths averted per $1 million spent, and your cost per capita, the same as in EQUIST, the site. So this is mainly, the enabling environment is also just any additional information for the enabling environment, but that we normally don't use in this version of EQUIST at this stage. This is mostly what you'll see on the summary page. There are other pages as well. Interventions, I think, is quite useful, where you can see these are the improvements in coverage on your scenario from baseline to end line. Baseline being the blue value, and then the red being end line. So how much you've improved per each intervention in terms of coverage. And it just gives you the source of your baseline data as well. There are some missing data rules, for example, that you can see, which show if the data was missing, what was used in its place or how it was calculated, and usually that detail is also available. So that's this file you can explore and take a look at, and to see how you could maybe present your scenario in the most effective way. And for investment cases, it would be good to show that you're achieving certain levels of coverage improvements and how that translates into deaths averted. So that was a scenario analysis on EQUIST. One final feature I'll show you is you won't have access to this unless you're a workspace administrator or data manager, is this setup button. If you have those roles, if you've been assigned those roles, there's an icon, the topmost right icon, which looks like a series of bars. If you select that, it brings you to a menu. It's a quick navigation menu. And if you have one of those roles, you'll see this setup tab. If you click that, you'll be taken now to the back end of EQUIST. So what we've just seen on everything I've showed you has been the front end, which all users have access to. But at the back end, if you're a workspace administrator for a certain country, so if I've been assigned these countries, so I'll pick a fictional country, what they call Mythica. If we look at the parameters for that, this is what a workspace administrator sees. So this is the level. There's a ton of parameters set up that you can do at the back end. So there's, I won't go over all of them, but just to highlight a few, if you have specific sources that you wanted to use, you can input them here and you can upload them. So for example, the maternal health survey, the file's been uploaded here, so it's available on the site. In terms of the administrative boundary and feature map, so what's being used for this are normally GeoJSON shape files. So you can see several different files being used, whether they be polygon, point, or line, to create the maps on EQUIST. And you can see marker symbols here for the layers. So looking at health facilities, looking at layers of lakes and rivers that can all be projected here and created on EQUIST. So here you can look at the breakdown of different features on the map as well. And further below that are in terms of the interventions and the indicators themselves. So with the intervention, if you select that, here's where you can do that mapping that I had mentioned in bottleneck analysis, where you have specific determinants. So if we were if we were to select a specific intervention, for example, under EMONC, magnesium sulfate management of eclampsia, and you selected this, you can actually set up which default indicators you want to use per determinant. So if you remember in step 4, we had the determinants per intervention and we had to assign indicators to. You can do that at the front end, but you can set up defaults at the back end. You can set up a primary indicator, and you can also set up secondary indicators. So as many as the system can allow here, you can set those up and make those selections, which may be easier during step 4 of scenario analysis. And I'll just skip down to the costing as well. So general costing parameter details, they can put in the GDP of the country, and as well as the additional costs due to road conditions of the target population. So this contributes to access to the population. And then there's also looking at staff training and costs as well, so the breakdown of costs for health workers as well. And I'll just skip ahead now to what the data managers also see. So in terms of data entry, you can select your workspace in a specific data set, and you can choose whichever types of data you want to enter, whether it be national, region, wealth quintile, and residence. You set the data, and what you'll get, here's the online version of the Excel sheet. So here's where you can go in. You can enter data straight away. You can put in a source, and you can enter, let's say, the population of Mythica is 750 million, etc. And you can go in and go through, and you can enter the data here, or if you prefer to work on Excel, you can export it. And it comes out as an Excel file, and you can work on the Excel file and then re-import the import file, and it will update straight away on this field, and it can be adjusted as well later on. So this is just in a very brief nutshell what's at the back end. It's just for the workspace administrator to customize and publish the data. And once they publish it, it'll show up on the front end of EQUIST. So that's how that works from the back end to the front end. And I think I'll stop there on the demonstration. I know it's a lot. It's a 5-day course packed in one session, but feel free to share any questions you may have, and we can then I think proceed to Robert's demonstration.
Proceed to lunch.
Proceed to lunch, then Robert's presentation, which connects to the outputs that you saw from scenario analysis.